So 5-FU is not a new drug. It's an old 60-year-old story where the initial studies found that 5-FU as a chemotherapy agent was useful, and we mainly use it now in GI cancers, sometimes in head and neck cancers as well. As you can see from this picture, the 5-FU is metabolized mainly by the enzyme called the dihydropyrimidinase dehydrogenase (DPD), and it is a ubiquitous enzyme, but it's mainly in the liver and also in the peripheral blood mononuclear cells. Now, going into the pharmacology a little bit more, you can see the DPD catabolizes about 85% of the 5-FU into inactive metabolites. And therefore, our doses are all based on the assumption that you're going to lose 85% of the active metabolites straight away. And there is a proportion of patients who will develop toxicity with 5-FU, and that is mainly driven by decreased activity of the DPD enzyme. Now, 5-FU is a toxic drug. Its major toxicities are hematological toxicities and GI toxicities in the form of diarrhea and oral mucositis. And those with decreased DPD enzyme activity will have toxicity, obviously. Now, how do we predict this decrease in DPD activity? Now, DPD deficiency can be partial or it can be complete. And the presence of DPD deficiency, as I'll show you in the coming slides, is a Gaussian distribution through the population. So throughout our population, we have people who are slow metabolizers, fast metabolizers, and the majority thankfully come somewhere in between. So partial deficiency is seen in only about 3 to 8% of patients, but a complete deficiency can be seen in a very small proportion of patients. And for these patients who do not metabolize 5-FU at all, the standard dosing regimens would be fatal. And the impact on those with partial or complete toxicity is that they'll have their toxicities early in the first 2 cycles. It can result in fatality, as I said, and it can also cause about 20 to 60%. Different studies have different values. We have seen about 40% of our patients having severe toxicities if you don't test for DP deficiencies at all. The presence or the understanding that there is a proportion of patients who do not metabolize 5-FU is also not new. It's been known for 30 years. And so, as I said, the 3 things are: one is DPD deficiency causes a decrease in catabolism, so the enzymes are high. On the other hand, you can also have the converse opposite. You can have high metabolizers who metabolize very fast, the drug levels are very low. And there is data to say that these patients have very low levels of 5-FU in the body and therefore have poorer cancer treatment outcomes. So the enzyme itself has nonlinear pharmacokinetics. There is a lot of interpatient variability, even among ethnicities. So this we know here is a study done even in CMC looking at the standard body surface area based dosing, which is what all of us do. And when we use the normal dosing algorithms for 5-FU, up to 50 to 60% of patients are outside the therapeutic range. They can be subtherapeutic or supratherapeutic. Normally in clinical practice, we measure DPD enzyme activity through 3 major ways. One is through the genotype testing, which is what most guidelines recommend, to do a DPYD gene testing to look for alterations that have a lower activity. The second way is a phenotype testing called the uracil test, or another phenotype test where you look at a ratio of dihydroplasma uracil to uracil. The advantage of the phenotype test is you are only looking at how that individual metabolizes the drug, and you are not testing for the exact genes that may be responsible. Now, why this is advantageous, I'll come to you. And the last way of testing is something called multiparametric testing. We don't do it in India. In fact, I don't think most of the world does it. Multiparametric testing is something that has been published and promoted in France. So the DPD phenotype test, as I told you, there are 2 ways to do it. One is to look at the uracil level, and the other way is to look at the dihydrouracil to uracil ratio. Both these in plasma will give you an assessment of the DPD enzyme activity in the body. The issues with the test are, one is it is not stable, so it needs to be processed immediately. It can be kept only for a few hours, 1 hour 30 minutes if it's at room temperature, only 4 hours of stability if it is stored at 4 degrees. And it has to be done empty stomach. A lot of interactions as well with food, with other drugs that you're taking. So a lot of issues in the test. And the sensitivity specificity across multiple studies have been variable, but they say around 82% sensitivity and 80% specificity. This is about the phenotype. The genotype, which is what most people talk about and most people do all over the world, is testing for the variants in the DPYD gene. So you can see pictorially represent the DPYD gene. There are about 700 variants described, and of them, they have identified 4 variants which need to be looked for specifically. But these 4 variants were identified in a Caucasian population. It was done on a population cohort from Europe. Now, what is this for an Asian or like us, Indian or African population? We don't know. There are no studies like that. And so, again, this test has a high specificity if it's positive, but a very, very low sensitivity. And the problems, again, are turnaround time. The test takes time to come, cost, etc. So, like I said, the population in the European cohort is about 8% of mutations. In ours, we don't know if it's lower or higher. There are reports of certain papers saying that Indian patients may have higher incidence of DPYD mutations, but we don't really know. So to summarize what I said so far, the testing of DPYD has a very poor sensitivity but a high specificity. Testing of uracil and dihydrauracil is a much more sensitive test, but you lose out on a bit of specificity. Ideally, you should do a multi-parametric approach where you look at genotype, phenotype, age, and other factors that may influence toxicity. So I'm just going to spend a little bit of time talking about our experience with this. So we started off testing about 80 patients initially, then expanded our cohort to about 235 patients who were treated with 5FU, and pre-treatment had the uracil and dihydrauracil ratio tested. So you can see there's a mix of different types of cancers who were treated at different stages in their disease journey, and different histologies as well. I'll move to the next part of what I'm talking about, which is measurement of osimertinib levels. I'm moving to a different entire subject altogether. So 15 years ago, 25 years ago, lung cancer treatment was non-small cell or small cell lung cancer, and the drugs changed, but their outcomes were, if they were lucky, if they lived a year. And that you can see in the median survivals as depicted on this graph. Then we came to the understanding that non-small cell lung cancer especially is not one disease, but is characterized by a myriad of different mutations. The commonest among them being the bottom, the EGFR mutation, representing about 30% of patients. This is in an American cohort. In India also, you can see the first graph, the black color, 25% of our patients are EGFR mutation positive lung cancers. Why is this important? Because we now have targeted agents which have significantly improved their survival. This is just an example graph from one of the recent trials, a drug called Osimertinib, which improved their median survival to about 38 months. So you can see where we were 20 years ago, where survival was only 10 months, to now where median 50% of patients are expected to live for at least 38 months, 3 years. So that's where we are, and that's why it's important to treat these patients well. Now, Osimertinib unfortunately has a few problems. The drug is, in India, the biggest toxicity we face with Osimertinib is financial toxicity. It's extremely expensive, and patients need to buy it. Now, if you're looking at a median survival of 3 years, that means patients have to buy it every month for that long. And that is, frankly, not affordable for many of our patients. From a scientific standpoint, Osimertinib has a half-life of about 50 hours. And it had a exposure AUC which increased in a dose proportional manner with increasing doses. But although the initial dose finding studies went from doses starting from 20 milligrams all the way to 240 milligrams, there was no proportional increase in response rates from around the 20 milligram dose. So they chose to go with the 80 milligram once daily dosing, but they could have gone with 40 milligram because frankly there was no improvement in response whether you did 20, 40, 80 or 240. And so our question was, can you maintain the efficacy and reduce the toxicity. And when I say toxicity, I'm talking about both the toxicity of the drug to the body as well as the toxicity which is financial. So we ran this trial. It was a single arm. What we did was a Simon's phase 2. That is, we had an initial analysis to see if what we're doing is safe, and only then went to phase 2 of the study. So together, everything was 39 patients who were enrolled. And what we did was we did an Osimertinib levels after cycle 2, and then an AUC monitoring at week 8. I'll skip through this quickly. So this represents the usual spread of EGFR positive lung cancer, which is about 45% female. We expected more female patients though. And they had the common sensitizing mutations, which is exon 19 and exon 21. So you can see here, our aim was, based on the published literature, was that the response rate was published as 87%. So our goal was we should not be less than 87%. So we set a goal of 89% or 90% response rates at 3 months. And you can see here that the response rate was 89.7 in these patients that we tested. If you look at the relationship between response rate and Osimertinib trough levels, it was a flat response curve. That again went ahead with what we had already known, that increasing the doses or even giving daily dose of Osimertinib doesn't improve their response rates. Our alternate day dosing strategy was working well. And if you look at the toxicity, there were a few patients who had high Osimertinib levels who also had high toxicities. And these toxicities came in the form of severe rash, diarrhea. The 2 patients had bad pneumonitis requiring stopping the drug and steroids. And we would not have known why they had these complications if we did not have the drug levels to measure. There was 1 or 2 patients who had subtherapeutic levels. We are still following them up to see what impact that has on their cancer treatment outcomes. As of now, we've reached almost 1 year of follow-up, and we've had only 2 patients who've progressed so far. So I have a few take-home messages. One is that TDM has always had a role in oncology, but it's having an increasing role. Of course, the older chemotherapy drugs, we always knew that it had a very narrow therapeutic index, and that's where the role of TDM is very important, to monitor the dosing and make sure that you're within the therapeutic index. But with newer drugs entering the market, and these drugs often are quickly run into the market, they may or may not have a strong rationale for why they've chosen that particular dose. So it's very important for us to go back, question it, and see how we can make it more applicable for each individual patient. And as everybody has been saying from morning, one size does not fit all. Thank you.
Dr. Abraham?
Yeah, on a practical note, in a patient diagnosed as a GI malignancy who require 5-fluorouracil as an adjuvant therapy, would you wait for the report to arrive or before starting treatment, or how long you'll wait, or should we start with a lesser dose? What is your practical way of treating such patients?
Yeah, so that's a good question. So basically, what we're doing now is we do the uracil testing now. That report is available within 2 days maximum. So we don't have to wait that long. Only for those, so we're using it now as a 2-step screening. So if they're normal, like I showed, the chances of them having toxicity is so low if everything is normal. So we treat them with the normal BSA-based dosing. Now, if it's abnormal, then we actually, we have cutoffs. For example, if it's abnormal and 16 to 150 is considered partial, and if only the uracil is abnormal, we still give 25% dose. If both are abnormal, then we wait. In fact, what we've seen is of these 250 patients, we had 2 patients who had both extremely abnormal. One uracil was 1000, the ratio was 0.1. So that's both are on the extreme high spectrum. So that told us that there is something wrong with their metabolism, and we found that both actually had a STAR2A mutation, which is basically they have 0 DPYD activity. If that patient was exposed, that patient would have died. So that is something that we picked up. There was another patient, interestingly, who had a heterozygous STAR2A, which means one parent would have given them the non-functional gene. The other gene should have actually been functional. So as per a scoring system for the genotype, you should have given them half dose. We gave 25% dose and the patient still had severe toxicity. So the genotype doesn't fully explain. Overall, looking at the whole picture, helps us. So in the practical perspective, the phenotype gives us an answer immediately. We know whether we need to dose reduce or not. And then we use the genotype as the next step.
Is there any difference between the capecitabine and 5FU?
Yeah, so we haven't found the difference actually.
We face many of our patients have a lot of toxicity with capecitabine because that require a pre-metabolism before converting into 5FU. So whether any impact on that metabolism and also it is a 14 days continuous dosing. So 5FU is it's only 46 hours dosing. So we found that many of our patients who do not tolerate capecitabine actually tolerate very well with 5FU. So only thing is like frequent dosing and hospitalization, other central line, all these things.
Yeah, so in this group we haven't found a difference like that.
Any questions, please?
If there are no other questions, I have a doubt. These cancer patients are anyway on some of these at least, are getting high cost treatments. So do you think that TDM, especially, I mean, take this example of DPD genotyping and phenotyping. We are doing 2 different tests, and I don't know the cost of the test. Do you think that TDM is affordable for our cancer patients? And does it financially make any sense? You have obviously talked about Osimertinib. Other than that, for 5FU, for example.
Yeah, so checking the phenotype definitely makes a lot of sense because for 2 reasons. The cost of the test is low, the turnaround time is short, and when we find a normal, which is what we find most of the time, majority of our patients are actually a normal phenotype. We don't have to then worry about the dose reduction or the time it takes. We are able to give them the standard dosing. Now we have not answered the question as to whether if they are normal, are they over-metabolizing, are they within the therapeutic range? We don't know that. We haven't reached there yet. But at least we know that we can do the standard BSA based dosing and it's safe for them, and our chances of toxicity is pretty low. So it saves them money in terms of what would happen otherwise. Otherwise, the standard is to actually do the genotype. Most people don't do it for the same reason that Dr. Abraham said. The time it takes for the test to come and the chances that it's positive is so low. And even after the test being negative, there's still a 30% chance you'll have toxicity. So most oncologists are like, why am I doing the test? The likelihood that you'll find something is so low. So this mitigates some of that. We are able to find a balance somewhere in between.